I want to start today by looking at the human body a little differently.
Okay.
We usually think of it as, a machine, right? Pulleys, levers, pumps.
That whole mechanical view. Sure.
Exactly. But I want you to picture it more like a landscape. Geography, you have hills, valleys, rivers running underground.
That's a surprisingly poetic way to open a medical discussion, but it's very accurate.
Right. And just like in nature, if a new hill suddenly appears where there used to be a valley, that's not just a thing.
It's a story.
It's a story. It tells you about the history of the land, the minerals in the soil, maybe even what happened there 10 years ago.
In clinical diagnosis, the body is absolutely a map and a swelling. That's a landmark that demands an explanation.
Exactly. And today we are going deep into one specific map. We're looking at a source that's essentially the Sherlock Holmes Manual for Surgeons. That's a case presentation by Dr. Ghanshyam Vaidya, specifically for final year medical students.
And I love this source because it strips away all the high-tech noise. We aren't starting with, MRIs or genetic sequencing. We're starting with eyes, hands, and questions. It's about how a doctor can stand in front of a patient and rule out life or death scenarios just by observing how a lump moves when they swallow. So, let's meet the mystery. We have a specific patient here. She's a 20-year-old female from the Thane district, and she walks into the clinic with one complaint: a swelling in her neck.
Yeah.
Okay, standard start.
But here's the detail that stopped me. She's had this swelling for 2 years.
Wow.
2 full years. And she says it is painless. Now, if I had a lump growing on my neck for 2 years, I feel like I'd be in the emergency room on day 3. Why wait?
That is the trap of the painless symptom. We're wired to react to pain. Pain is an alarm bell.
Right.
But a slow-growing, painless lump, it just feels benign, it feels harmless, it's easy to ignore or, to adjust your collar and pretend it isn't there.
But for a doctor.
But in oncology, and especially in thyroid surgery, painless is often the word that makes a doctor nervous.
Because pain usually means infection or inflammation.
Yeah.
Something hot and angry.
Right, infection hurts. Cancer often doesn't. Not at first. So the fact that this girl from Thane sat with us for 2 years tells us a lot about the nature of the pathology. It's slow and it's silent.
So the doctors start their investigation. And looking at Dr. Vaidya's breakdown, the first segment is the history. But it's not just when did it start.
No.
They spend a huge amount of time listing what she doesn't have. I felt like they were trying to prove a negative.
This is such a critical mental model. It's called negative history.
Yeah.
Sometimes the dog that didn't bark is the most important clue.
Okay. In thyroid cases, you have a lump. The immediate burning question is this lump a factory? Is it churning out hormones, so they're checking if the engine is revving too high?
Precisely. They are looking for toxic goiter or thyrotoxicosis. And the list of things she didn't have is fascinating. She didn't have palpitations. Her heart wasn't racing. She wasn't losing weight despite having a huge appetite.
That's the one everyone knows, right? The I can eat whatever I want and lose weight symptom. Which sounds great until you realize your body is basically eating itself.
It's like driving a car with the pedal floored while in neutral. You're burning fuel, but you aren't going anywhere. It's exhausting for the system.
And she didn't have tremors, insomnia, or diarrhea either.
Her system wasn't running hot. And the source also mentions she had no change in voice and no dysphagia, difficulty swallowing.
Which is good news.
It's great news. If a 20-year-old has a change in voice, it implies the lump is attacking the nerves controlling the vocal cords. That implies invasion.
Malignancy.
Malignancy. The fact that she can talk and swallow normally suggests the lump is, for now, respecting its neighbors.
Okay, so we've established what it isn't. It's not a toxic hormone spewing factory. Now, the detectives look at her background. You mentioned geology earlier. The force makes a big deal about her being from the Thane district and then pivots to talking about the Himalayan ranges. What is the connection there?
This is where the landscape concept becomes literal. The thyroid needs iodine to build its hormones. That's the raw material.
And where do we get iodine?
From the soil, from our food and water.
So if the dirt is bad, the thyroid goes bad.
Essentially, in the Himalayan belt, the soil is notoriously iodine deficient. The water lacks it. So people living there often develop goiters and large thyroids because the gland is frantically trying to grab whatever tiny scraps of iodine it can find.
It grows bigger to become a more efficient trap.
It's compensating.
Like a baseball player using a giant mitt because the ball is too small.
That is a perfect analogy, the endemic goiter. If our patient came from a village where everyone had a swollen neck, we'd suspect the water immediately.
But she's from Thane.
So it's less likely to be purely environmental, but it's still on the suspect list. You have to ask.
Now, speaking of things we put in our bodies, I have to ask about the cabbage. The source explicitly asks about eating cabbage. I had coleslaw yesterday.
Should I be worried? I knew you'd catch that. It always makes people pause in the produce aisle. Here's the deal. Cabbage, cauliflower, kale, the brassica family, contain chemicals called goitrogens. Goitrogens. Even the name sounds villainous.
It does. These chemicals can inhibit the thyroid's ability to use iodine. So technically, yes, they can cause a goiter. But, and this is a big but, you would need to eat a truly massive amount of raw cabbage. We're talking a strictly cabbage-based diet for months.
Okay, so my side of slaw is safe.
You are safe.
Right.
But in clinical history taking, if a patient has a very specific restricted diet that is heavy in these vegetables, it's a clue. You have to ask. It's about ruling out every variable.
There is one more variable in the history that felt much heavier than cabbage. Radiation. The source flags childhood radiation exposure as a major red flag. This is the dark horse. If you ask a patient, did you have radiation therapy to the neck as a child? Maybe for something benign like swollen adenoids, which used to be common practice decades ago, and they say yes, the temperature in the room drops.
Why? What does that change?
It skyrockets the risk of papillary carcinoma thyroid cancer later in life. Radiation scatters the DNA in those thyroid cells. Years later, that damage manifests as a lump.
So a history of radiation would make this taintless lump look
Like a ticking bomb, exactly.
But in her case, no radiation, no cabbage obsession, no toxic symptoms. So now the doctor actually touches the patient, the inspection. I love the description of the maneuver here because it felt so specific. They don't just stare at her neck. No, you can't just inspect the neck. That's relaxed. It's too soft. Things hide. The source describes the method. The patient clasps their hands behind their head and presses their head backward against the resistance of their palms. It sounds like a stretch I do at my desk. Why this specific move?
Think of the neck as a crowded tunnel. You have the windpipe, the esophagus, arteries, muscles, all packed and tight. When she presses her head back like that, she is tensing the muscles in the back, but more importantly, she is relaxing the sternocleidomastoid muscles.
Those big V-shaped strap muscles in the front of the neck.
Exactly. She's relaxing the curtain so you can see the stage. By relaxing those straps and pushing the neck structures forward, the thyroid gland is thrust out. Any lump becomes much more prominent.
It pucks out.
It pops out.
And when our patient did this, what popped out?
A single oval swelling, about 3 centimeters by 2 centimeters, right side, just above the collarbone. But the visual detail that matters is the surface. The source notes a smooth surface and well-defined margins.
Smooth sounds friendly. Knobby sounds bad. Is it that simple?
In the world of lumps, yes, it often is. A smooth surface usually suggests a simple cyst or a benign colloid nodule. It's contained.
And if it was irregular?
If the surface was irregular bossylated like a cluster of grapes, we'd worry about a multinodular goiter. And if it looked jagged or ill-defined, that hints at cancer breaking the boundaries.
There's another test here that I thought was brilliant, the tongue test. The doctor asks her to stick her tongue out. How does that tell you what a lump in your neck is? They seem totally disconnected.
They seem disconnected now, but in the embryo, they were best friends. The thyroid gland actually starts forming at the base of the tongue and then migrates down the neck to its final resting place.
It migrates, like a bird.
Like a commuter. It travels down a path called the thyroglossal duct. Sometimes it leaves a remnant behind a thyroglossal cyst
And that cyst stays connected to the tongue.
by a fibrous cord. So if you have a lump in the midline of the neck and you stick your tongue out,
The tongue pulls the cord, and the lump moves up.
bingo. It's a puppet on a string. If the lump jumps, it's a cyst. In our patient's case, the lump stayed put.
But it did move when she swallowed.
And that's the key. It confirms it's thyroid tissue because the thyroid is attached to the larynx, which moves when we swallow.
So we know it's the thyroid. Now we get to palpation, the hands-on part. And the source mentions Lowe's method. The doctor stands behind the patient.
Yes, always from behind. You get better leverage. Imagine trying to feel a specific grape floating inside a water balloon. If you just poke at it with one hand, it slides away.
So you need to trap it.
Right. Lowe's method is about trapping. The doctor uses one hand to push the trachea and the muscles away from the opposite side. They're literally shoving the contents of the neck over.
Making the grape bulge out against the skin.
Exactly. It fixes the gland so you can run your fingers over it and determine the consistency. And this, for me, is the most visceral part of the exam, the feel of the thing. The source uses 3 words: soft, firm, and stony hard. And every doctor knows exactly what those feel like. Soft feels like your cheek when it's relaxed. That's usually a physiological goiter. Firm feels like the tip of your nose, solid but elastic. That's what our patient had.
And stony hard.
Ideally, you never want to feel that. It feels like touching your forehead or a knuckle. Unyielding.
That's terrifying.
If a lump in the neck feels like a rock, the alarm bells are deafening. That is the hallmark of anaplastic carcinoma, or a calcified malignancy. It suggests the cells have become rigid, invasive, and dangerous.
The phrase stony hard makes me shudder. It implies something dead or inorganic growing inside you.
It is a chilling find, and the source lists a malignancy checklist that goes along with that hardness. If the lump is hard and it's fixed, meaning you can't wiggle it, it's glued to the muscles, that's bad.
And there was one sign that really got me. Barry's sign, the pulse.
Yes. The carotid artery runs right next to the thyroid. Normally, a benign lump pushes the artery aside. You can still feel the pulse. But a malignant cancer, it doesn't push, it envelops.
It grows around the artery.
It grows around the carotid sheath, so when you try to feel for the pulse, you can't find it. The mass is suffocating the artery. That is Barry's sign. If you can't feel the carotid pulse because of the lump, you are dealing with something very aggressive.
Wow. Okay, so our patient luckily had a firm nodule, not a stony one, and she had a pulse. But we aren't out of the woods. The source discusses deep dangers.
The iceberg problem, retrosternal extension. Sometimes the thyroid grows downward behind the sternum into the chest cavity.
And the chest is basically a bone cage, right? There's no room for guests.
Zero room. It's a packed elevator. If the thyroid forces its way in there, it starts crushing the other passengers. And the most important passenger is the trachea, the windpipe. The source uses a term for this that sounds like something from a fantasy novel, the scabbard trachea. It's a vivid image, isn't it? A scabbard is the flat sheath for sword. If you take a round tube like the windpipe and compress it slowly from both sides for years, it flattens out. It becomes a slit,
So the patient's trying to breathe through a coffee stirrer.
essentially. And the scary part is, they might not realize it at rest. But if they catch a cold or need to run for a bus, that tiny slit closes up. That is respiratory embarrassment.
Which is a very polite way of saying suffocation.
It is. That's why doctors do Kucher's test. They gently compress the lobes of the thyroid from the sides while the patient takes a deep breath.
And if they choke,
If they choke, if you hear stridor, a high-pitched gasping sound, the airway is compromised.
that would be the moment to book the operating room immediately.
Without a doubt, you cannot medicate a crushed windpipe. You have to physically remove the pressure.
There's another pressure point mentioned that leads to Horner syndrome. This felt like a wiring problem. The lump is in the neck, but the symptoms are on the face.
The body is wired in strange ways. There is a bundle of nerves called the cervical sympathetic chain that runs down the neck. It controls things like pupil dilation and sweating on the face. If a thyroid cancer presses on that nerve bundle, it cuts the power cord.
And the face goes haywire. Specifically, 4 things happen on that side. 1,
Mhm.
ptosis, the eyelid droops. 2, meiosis, the pupil constricts to a pinprick. 3, anophthalmos, the eyelid's sunken. And the 4th.
And hydrosis, you stop sweating on that half of the face.
Wow. So if you see someone with one droopy, dry, sunken eye, you need to check their neck.
100%. It's a classic example of how everything is connected.
Okay, let's bring it back to our girl from Thane. She didn't have the droopy eye, she didn't have the crushed windpipe, she had a firm, smooth, solitary nodule. What is the verdict?
The diagnosis is a non-toxic solitary thyroid nodule. It's the most likely scenario, but likely isn't enough in medicine. You need certain, so the toolkit comes out.
Blood test, x-ray.
And the MVP is the needle, the FNAC. Fine needle aspiration cytology. Before you cut someone open, you stick a tiny needle into the lump, suck out some cells, and look at them under a microscope.
That tells you if you're dealing with good guys or bad guys.
It's the blueprint.
Now, let's talk treatment. This part felt like a choose-your-own-adventure book.
Yeah.
For our patient with a solitary nodule, they choose surgery. But it's a specific kind of surgery with a halftime show.
That's a good way to put it. It's called a hemithyroidectomy. They plan to remove just the half of the thyroid with the lump, but the halftime show is the frozen section.
Walk us through that. The patient is asleep on the table. They cut out the lump. Then what?
She stays under. This is high drama. The surgeon takes the lump, puts it in a sterile container, and literally runs it to the pathology lab down the hall. The pathologist freezes it instantly, slices it paper thin, and looks at it right then and there.
And the surgeon is just waiting.
Scrubbed in, hands in the air, watching the clock. The whole team is paused. If the pathologist calls back and says benign, the surgeon sews up the neck and the patient goes home with half a thyroid.
And if the call is malignant,
Then the plan changes instantly. The surgeon goes back in and removes the entire thyroid gland, a total thyroidectomy. It all pivots on that one phone call during the surgery.
that is intense pressure. Let's briefly touch on those malignant options. Let's start with papillary carcinoma.
Papillary is the most common. Think of it as the neighbor. It tends to spread locally to the lymph nodes right next door in the neck.
So the surgery is bigger.
It involves taking the thyroid and sweeping out those lymph node neighborhoods.
Okay. Then there's follicular carcinoma.
Follicular is the traveler. It spreads through the blood, not the the lymph nodes. It likes to go to distant lands, specifically the bones.
Oh, bones. That seems so random.
It is insidious. That's why, for follicular cancer, after you remove the thyroid, you don't just check the neck, you do a bone scan. If you find cells in the bones, you treat them with radioiodine.
The targeted missile.
Exactly. The thyroid cells are the only cells that crave iodine, so they eat the radioactive dose and die.
And finally, the one the source seems almost afraid to mention. Anaplastic carcinoma.
This is the wildfire. It is aggressive, fast, and messy. It ignores boundaries. It grows into the muscles, the trachea, the skin. By the time you find it, it's often too late to cut it out because it has no edges.
So what's the treatment?
You rely on radiotherapy just to slow it down. It is a diagnosis no doctor wants to deliver.
It really underscores the stakes here. We started with a painless lump, a nuisance. And the spectrum of what that lump could be ranges from you need more iodine to wildfire cancer.
And that is the beauty of the clinical method Dr. Vaidu is teaching. It's about navigation, using questions about cabbage and village wells, and using hands to feel for stony, hard ridges to steer that patient away from the cliff edge.
So bringing it all back to the beginning, the 20-year-old from Thane, the frozen section likely comes back benign. She goes on to live her life. But for us, for the listener, what is the takeaway?
For me, it's about respect for the body's signals, even the quiet ones, especially the quiet ones.
The silence of the symptom.
Exactly. We live in a loud world. We react to loud pain. But this case teaches us that pathology can be patient. A stony, hard lump doesn't scream, it just sits there, waiting for someone to notice the landscape has changed.
And that's the provocative thought I want to leave you with. How well do you know your own landscape? If a new hill appeared on your map, would you notice it if it didn't hurt?
It's a question worth asking in the mirror.
Check your necks, maybe ease up on the raw cabbage smoothies, and keep exploring. Thanks for listening to this deep dive.
See you next time.